Thank you, Chairman Sanders and Ranking Member Barr, for having this very, very important meeting. And I want to thank you all for being here. I know that you're working very, very hard to try and resolve these things. I also want to commend you, Mr. Gibson, for getting out to the, to the places that are really struggling, and then also the places that are doing well, and trying to figure out best practices, and then again why others are struggling so much. Dr. Perlin, I think, is important, in the situation of bringing him on as an advisor. I think that was really a very, very good move. In regard to the your request, as far as additional personnel and things like that, is that based on current practice, or is that based on reforms in the future that are going to, significantly change things, hopefully?
Sure. The methodology we used is largely framed in the current context, Senator Boozman. So what we looked at is looking at our current appointment volume, looking at our current delays in care, forecasting those through the years, and trying to attenuate them year on year. So it's not any subsequent reform, it's in our current context.
Right. I had the opportunity to serve with Tom Osborne over in the House, the great coach from Nebraska, and people used to talk to him about winning. And he'd say, we didn't ever talk about winning. What we talked about was doing the little things. And one of the little things that has to be done, and I'm a little bit concerned because you said it would take 2 years, and probably in VA lingo, that's probably more like 4 or 5, is the scheduling. That's one of the little things that if you don't get that done, tomorrow, my understanding is they don't call people the day before and tell them they've got an appointment. You could cut your no-show rate significantly just by doing that, and then taking somebody that's on a backlog and sticking them into those slots. That's just common sense practice that's done throughout the country with anybody in the private sector. So you have to get the scheduling under control, and there's no reason not to do that in a rapid situation, particularly targeting the areas that are having problems. Your facilities that are doing okay right now, by whatever standard you're measuring, but it does seem like you would put that in place right away.
You may have missed the comments earlier. There are actually 4 different major initiatives underway on scheduling. One has to do with fixing existing issues. There are 11 of those fixes that are in the process right now. There are 4 separate applications under development to make it easier for schedulers to interface with the system, as well as to give veterans the ability to directly request schedules. There is a contract that's already been let that will make major modifications to the existing scheduling system. Was let on the 11th of July, and we expect that to bear fruit in the May through August time period of next year to deal with some of the toughest, some of the most difficult issues associated with the existing scheduling system. All of that is in parallel while we are working to acquire a commercial office.
There are good over-the-counter systems right now in place that major medical centers are using without any problem at all. That's the basis of medical practice.
You want to answer this one?
Sure. I would agree with you, sir. I think that you have 2 comments. One of them is the underlying system, and I think there was a reference made to a prior system effort. I don't think we're looking to go build something from scratch this time.
I would hope not.
We're not.
Like I said, that's something that people have been doing for years, and I'm an optometrist by training, and again, that is the basis of your practice, is scheduling. You mentioned that 1 assistant per specialist, and I would, right now in the VA system, and I think you said 2.5 or whatever, that might even be a little bit low. But what I'd like to know is, what is the relationship between, if you take a major VA medical center and you look at total staffing, you look at the staffing that it takes to support that medical center, okay? What is the comparison with a major private entity as far as numbers?
I don't have the exact percentages, but if you look at the overhead rate in the VA or the indirect rate in the VA for support staff, it's considerably lower in each one of our major areas, primary, specialty, and mental health. I don't have the specific counts.
As far as the total numbers, I'm talking about administration, the whole bit.
I'm looking just at the field costs, not looking at everything else for a blended overhead rate. I think we could come up with something like that that would look at a blended rate and see where the different overhead and G&A charges come in. But in terms of what we have in our facilities, the labor share is lower in the VA for support than it is in the private.
Not as dollars, but people.
In terms of people, it's lower in the VA than it is in the private sector. What you may be asking as well would be, could we construct a blended rate that looked at the overall cost factors? We could. We have not done that.
Okay, I'd like to see that. I think that would be interesting. The other thing is that right now, if you go to your Medicare doctor, if you're a veteran and you get you have a physical and the Medicare doctor decides that you need high blood pressure medicine, and then you go to the VA, instead of filling that prescription, which is a pretty good deal, for the veteran, they have to have a physical in order for that to be done.
I understand.
Why is that? I mean, is there any logical reason for that at all?
Well,
How many slots would that free up if you made that one change? How much money would that save?
I am not a clinician, so I can't, in a learned way, describe why that is the case, but there are certain reasons why that would be appropriate and why that does make sense. But I will tell you that we are looking at things like referrals to audiology and where that could obviate, where we could bypass the primary care step as an additional item. But we need to look at that carefully, and I think folks are looking at that now. Audiology, optometry, ophthalmology, maybe some pharmacy, not all pharmacy, we need to be careful, but we are looking at that.
No, I can see the scheduled drugs and things like that, but to me it makes no sense at all that if a guy that is licensed and taking Medicare dollars, another entity that is licensed by the government, why a prescription can't be filled for diabetes, high blood pressure, the vast majority of stuff that actually comes across. Could you look and see how many slots that would save?
We will look at that. But the one thing, just one point of caution would be not to overcorrect in that direction. But we do have folks looking at the pattern between primary care and certain specialty, the pattern between primary and pharmacy.
How do you mean overcorrect?
Just to not be vigilant for pharmacy fill requests that would be coming in from the private sector. That's the only thing that I mean. Just to make sure that we're determining the appropriateness of certain prescription fills. And the examples that you've given, they seem pretty straightforward, but we just need to make sure that those are the only examples.
There is a large percentage of veterans that are served by both VA and Medicare.
Yes.
And so part of this is understanding what the second and third order effects are of the kind of change that you're talking about. Clearly, one of the impact would be that it'd free up primary care slots. Got it. That's a good thing. Mm-hmm. What are the second and third order effects? And that's, I think, Philip's point about being
well, it probably would decrease the backlog.
Pardon?
It probably would decrease the backlog if you had primary